Benefits of regional anesthesia in cancer surgery. All right, Dr. James, take it away. You just let me know when to advance those slides.
Yes, Tim, thank you so much. Good afternoon, everybody. I'm so excited to be able to return and talk on the network once again on topic of pain as well as anesthesia, because being an anesthesiologist, that's certainly area of interest for me. So thank you so much for giving me this opportunity to present you with evidence in support of use of neuraxial techniques for pain management in cancer patients undergoing surgical interventions. Next slide, please. During this presentation, I would like to discuss why the perioperative period is such a critical period in terms of influencing outcomes of cancer surgery, in particular as pertaining to long-term cancer survival as well as risk of cancer recurrence. And although the title of this presentation focuses primarily on neuraxial anesthesia, and that's mostly what we're going to talk about, we will also touch on other matters pertaining to anesthetic techniques and how it influences cancer outcomes. In particular, I would like to address it in terms of effects of perioperative anesthetic management on our immune system and how diminishing the perioperative stress using regional anesthesia techniques can in fact positively impact cancer outcomes. Next slide, please. And twice more, please. Patients suffering from cancer receive various types of treatment. Early on, cancer treatment was focused primarily on surgery and radiation therapy, and we all know that those therapies are quite drastic and can be, in fact, detrimental to human health. Subsequently, the treatment evolved into provision of chemotherapy, and then within the last decade or two, there have been significant advances in the field of oncology in terms of development of targeted drug therapy, immunotherapy, hormone therapy, which appear to be more cancer type specific and a bit less systemically destructive as opposed to those old cancer treatments. Ultimately, however, the goal still remains the same, and that of course is cancer eradication and patient survival. Next slide, please. Despite the substantial advances in cancer therapy and various cancer treatment, oncological surgery still remains #1 therapeutic option for most solid tumors. Therefore, patients undergoing surgery, of course, will be exposed to various types of anesthetic management. And I think we have a poll question coming up next. If you can please move, yeah, okay. And where's the question?
All right, so the question is, which treatment is associated with highest risk of chronic pain? And so for those of you using the text, you can use the A, B, or C, or D. A is chemotherapy, B is radiation, C is surgery, or D, all above equally. So please take just another 10 seconds or so to think about that and go ahead and submit your best answer. All right, Dr. James, how are they doing?
So there's the question, thank you. So although all of those therapeutic options certainly can contribute to chronic pain, surgery is absolutely the worst. Some of the surgical techniques, some of the types of surgery that are utilized in cancer management are quite extensive and debilitating. And surgery is definitely #1. Next slide, please. Unfortunately, even though it carries such a significant morbidity, ultimately surgery is the only curative treatment for so many cancers, and the cancer has to be resected in order for the patients to be able to recover. However, despite resection, Recurrences of cancer very frequently occur, as you all know. And one way to explain those recurrences, why do those recurrences do occur despite the fact that the entire cancer was thought to be resected during the surgery, is due to surgery-related micrometastases, ultimately leading to angiogenesis and then also being negatively affected by the surgery impaired immune system function. So let's discuss briefly how do those events within the perioperative time frame shape long-term cancer outcomes and why. Can I have next slide, please? So we will, during this talk, we will discuss how the outcomes of cancer surgery depend on a very delicate, very tenuous balance and a constant battle between human immune system function and the tumor microenvironment, which either results in tumor destruction or allows for tumor progression and dissemination. So let's talk a little bit about immune system function as pertaining to cancer detection and eradication. And I know, I'm certainly not a cancer expert, so please bear with me. I believe many of you know much more about it than I do, but I will certainly try my best to convey this information. Next slide, please. So why is cancer so tough to kill? Cancer has been long viewed as a disease consisting of transformed cells acquiring this autonomous, hyperproliferative, invasive qualities. And on top of that, having pretty much limitless survival capacity, being poorly responsive to apoptotic signals. Next slide, please. So we know that cancer cells are super tough to kill as they no longer behave like normal cells. They have now acquired new skills, which include ability to evade immune surveillance by immune cells, as well as endless potential to replicate. What is even worse is that cancer cells simply refuse to die. They lack the ability to respond to the normal apoptotic signaling. And as long as nutrients and resources are available to those cells, they will continue to grow and disseminate, spreading to other parts of the body. In order to enhance these processes, cancer cells are characterized by uncontrolled production of growth factors and lack of response to the anti-growth factors. That in turn leads to angiogenesis, which means production of the new blood vessels, blood vessel invasion, and then spread to other tissues. Next slide, please. Under ideal circumstances, a well-functioning immune system should be able to allow us to avoid cancer due to early detection of those cancerous cells and their eradication. Our lymphocytes are in fact programmed to constantly survey tissues for cells who have undergone mutation and become cancerous, as those cells are different from normal cells and they are now expressing antigens on their surface that are very specific for malignancy. Tumors, however, tend to develop when immune system surveillance breaks down, or alternatively when the immune system is not strong enough to be able to neutralize those cells. Next slide, please. Among the lymphocytes involved in immune system functions, T cells are by far the most important. They are the primary lymphocytes involved in cancer detection and cancer eradication. T cells can be divided, as you see on the slide, essentially into two groups: the cytotoxic T cells, which are the CD8s, and the helper T cells, which are the CD4s. Cytotoxic T cells otherwise are also known as natural killer cells. They are large, granular lymphocytes. They do not perform phagocytosis, and they destroy cancer cells by trying to perforate their membranes with enzymes, or alternatively by acting by triggering an apoptotic event and then self-destruction by the cancer cells. The helper T cells, which are the CD4s, are also very important in cancer cell detection and eradication, as they have a major regulatory function of virtually the entire immune system. They produce lymphokines. Lymphokines are substances, in fact, mediator protein that enhance function of the killer T cells, as well as increase production of lymphocytes within the bone marrow. They can also augment the immune response by increasing B cell antibody production. So they affect B cells. Antibodies produced by B cells are protein that also protect our body from invading agents and have been shown to kill cancer cells by blocking those growth factors that influence cancer growth and expansion. Next slide, please. We know, in fact, and this is not questionable, and multiple studies have been done on it. We know that chronic stress causes chronic pro-inflammatory state within our body, characterized by systemic elevation, continuous elevation of pro-inflammatory mediators and stress hormones, which do in fact contribute to immune system compression, ultimately potentially leading to either increased risk for infections or cancer. Please press 3 more times. And there's multiple studies that support this notion. Next slide, please. But how about acute stress? How about acute perioperative stress as related to preoperative anxiety, the stress of pain, the stress of surgical insult, as well as postoperative stress? Next slide, please. So let's briefly discuss what happens to us, or should I say to patients, to cancer patients, in terms of stress during the perioperative period. The entire process for most of us starts with already heightened stress level because of the preoperative anxiety. I don't know that I have ever met a patient who kind of goes happy-go-lucky and is not bothered by the fact that they are going to undergo cancer surgery. So this perioperative stress is then further escalated by the surgical insult of incision and tissue manipulation. All of that stress results in activation of the sympathetic nervous system, of activation of the hypothalamic pituitary axis, ultimately leading to rise in circulating catecholamines and immune system suppression. You guys all know that steroids do not work well with the immune system. And what happens when there's a lot of stress? Cortisol and all kinds of other catecholamines cortisol is a steroid, but also other catecholamines are being released, stimulating the sympathetic nervous system. Intraoperatively, patients often are exposed to other immunosuppressive factors, such as uncontrolled body temperature, either hypothermia, hyperthermia, unusual levels of blood glucose, either are hypo or hyperoxygenated with oxygen, immunosuppressive drugs, blood transfusions also do the same thing, suppress immune system. So there's a lot of stuff going on within the perioperative time frame that can affect patients' immune status. And I think we have a poll question coming up again. Can you go to the next one?
We do. So which of the perioperative factors listed below does not contribute to cancer surgery outcomes in terms of recurrence and survival rates? So you can choose A, medications used for perioperative pain management, B, preoperative anxiety level of the patient, C, preoperative use of NSAIDs, D, surgical technique, or E, type of malignancy treated. So again, we've got those 1, 2, 3, 4, 5 options, and looks like we're coalescing around one in particular. Take just a couple of more seconds, please. All right, Dr. James, looks like people are thinking preoperative use of NSAIDs might be the answer. That's where we have the majority of responses. We'll go ahead to the next slide. How did they do?
And they did excellent because that's precisely the answer. So although many of you may be a bit confused because you may know that certain studies suggest that use, for example, of aspirin has been known to decrease colon cancer risk, that is not a perioperative use. So when you're using NSAIDs, immediately prior to surgery, that would not affect the cancer outcome, the surgical cancer outcome. On the other hand, surgical technique, anesthetic techniques, and types of malignancy definitely matter in terms of cancer outcome. Let's go to the next one. So knowing now that the perioperative stress causes immune suppression, and immune suppression can potentially contribute to development or metastases of cancer, we must now ask ourselves, can choice of anesthetic technique affect cancer recurrence or metastases? Does it actually matter what an anesthesiologist does in the operating room in terms of whether the cancer will be eradicated or not? Next slide, please. As an anesthesiologist, we may not always be able to control all of those parameters. We certainly strive to. We should definitely aim at creating the most optimal anesthetic plan for the patient. The key is to try to avoid anesthetic drugs that have been already found to have immunosuppressive qualities. And one of the worst ones are probably the volatile anesthetics. Volatile anesthetics are the medications that the patient breathes through the breathing tube throughout the entire case that actually keep them to sleep. And although they are used most frequently during general anesthesia, other options such as totally, IV anesthetic are also available. Other medications, as you see, that we often use in anesthesia are, of course, opioids, which are primarily used for pain management, and medications that you may not be quite as familiar with, which are anesthetic drugs such as ketamine and thiopental. On the other hand, medications such as propofol, local anesthetics, and NSAIDs have been found to have beneficial effects on cancer outcomes. And the main idea behind their action is basically that they have some anti-inflammatory effects, therefore contributing to better outcomes. Next slide, please. There is, in fact, significant scientific evidence, as shown by a list of few studies, suggesting that opioid receptors modulate function of the immune system, and as such may be involved in modulation of tumor growth and metastases. And how many of cancer patients are on opioid medications, not just in a perioperative setting, but also chronically for pain control? So many. Yet opioids are truly not the best for cancer. Many molecular studies suggest that opioids promote angiogenesis, which is the development of the new blood vessels, and suppress function of the natural killer cells, inadvertently contributing to tumor progression. Although the mechanisms behind those immune suppressive effects of opioids are very complex and yet not completely understood, at least some of those effects are attributed to increased density of new opioid receptors on tumor cells. And those are the same opioid receptors that are responsible for analgesia. Binding of opioids to these receptors promotes tumor growth and metastases. Conversely, if you take tumor cells and you expose them to opioid antagonists, it has been shown to decrease cancer progression and spread. Next slide, please. In similar fashion, there's growing evidence suggesting that volatile anesthetics used during general anesthesia, those are the breathing agents, tend to impair function of immune system and contribute to poor cancer outcomes. Next slide, please. Although precise mechanism of effects of volatile anesthetics on tumor cells is not fully understood, what we do know is that volatile anesthetics have been shown to contribute to tumor growth, tumor proliferation, They enhance production of pro-cancer molecules as well as new blood vessels sprouting, which possibly can lead to distant metastases. Next slide. Oh, we're up on not a poll.
So which of the anesthetic medications listed have not been associated with worse cancer outcomes? And so A, opioids, B, propofol, C, volatile anesthetics, or D, ketamine?
I am so pleased because it looks like everyone's listening, because you guys are 100% of you are correct. Propofol actually has beneficial effects. And for those of you who are not familiar with propofol, propofol is the medication that we use for induction of anesthesia. However, if somebody wants to avoid using volatile agents, we can also continuously infuse propofol throughout the surgery to keep patient anesthetized. Next slide, please. So, of course, where do we go from here? Next slide. We can certainly consider more balanced, more appropriate anesthetic, using medications known for their beneficial effects on the immune system, propofol, local anesthetics, NSAIDs, and avoiding those that have negative effects. These medications have been shown to enhance function of immune system perioperatively, propofol, local anesthetics, and NSAIDs. Next slide, please. Local anesthetics, in fact, are the primary drugs used in epidural infusions. I wonder if anybody knows what the other drugs that we commonly use in epidurals. And they are actually not beneficial for cancer. So another drug that we often put in epidurals are actually opioids, saying that the amount of opioid within the epidural is at least 10 times less than what a patient would require via IV. So although we recognize that opioids do have negative effects on cancer, we certainly hope that at this, minute quantities that are being placed in epidurals, that those effects are not significant, okay? So the local anesthetics are the primary drugs used for epidurals. They can also be infused intravenously during anesthesia and are nearly always, unless somebody has an allergy or there are other contraindications, administered as a bolus anesthesia to neutralize the various sympathetically mediated reflexes associated with that stimulation. Local anesthetics, for example, have been found to modulate activity of a variety of immune cells. Can you click one more time, please? They tend to potentiate natural killer cell cytotoxicity. They facilitate antigen presentation. They have been shown to enhance function of neutrophils, function of macrophages, and even dendritic cells. Next slide, please. It is also postulated that exposure of cancer cells to local anesthetics produces cancer cell surface sodium channel block. I know it's really long. So basically, if you expose cancer cells to local anesthetics, and the local anesthetic is able to block the sodium channel on its surface, that in turn causes demethylation of tumor cell DNA, ultimately leading to its death. So clearly, local anesthetics have benefits. Next slide, please. Local anesthetics also act on several steps of the metastatic process. They are thought to do it by decreasing serum concentration of the metalloproteinase 2, by inhibiting angiogenesis, therefore impairing cancer cellular migration and invasion, and also by reduction of all the pro-inflammatory cytokines associated with cancers, things like tumor necrosis factor as well as interleukin 6. Next slide, please. Systemically used NSAIDs, and please click like 5 more times, have also been shown to improve cancer outcomes by inducing cancer cell apoptosis and by enhancing activity of the standard chemotherapeutic agents that we use in cancer treatment. This is thought to occur due to overexpression of the COX-2 enzyme receptors by tumor cells. And there are multiple studies that suggest benefits of various NSAIDs in cancer prevention as well as cancer treatment. Next slide, please. So this study done by Forget, I believe it's pronounced, in 2014 illustrates benefits of use of perioperative ketorolac and then further diclofenac in breast cancer surgery. So the graph on the left illustrates disease-free survival time frame versus the graph on the right illustrates overall survival. And as you guys can see, for patients that utilize NSAIDs perioperatively, the survival is longer than for those who have not. Next slide, please. So we have now talked a lot about anesthesia and various anesthetic and analgesic drugs in general, and how we use them in the entire anesthetic process. But how about regional anesthesia? In particular, neuraxial anesthesia. What is it and how can this affect? So neuraxial anesthesia, just like the name says, it's basically numbing up the nerves as they arise at the level of the spine within a spinal column and then exit the spine to innervate our torso and our extremities. The most common type of neuraxial anesthesia is in fact epidural. Thank you for, yeah. So there are two different kinds of blocks that I would like to talk to you about today. One being epidural blocks and one being paravertebral blocks. So in the end, once the block is performed, they act in a very similar fashion, but blocks in itself are very, very different. So on the left side, you see a picture of the epidural placement, which means it's just, straight in the middle, goes into the spinal canal, and then medicine is injected there and bathes the nerves or potentially the, excuse me, the spinal cord. In the paravertebral block, the block is placed either to the right or to the left, laterally to the spinal column. However, where the medication is injected, a lot of that numbing medicine actually spreads medially and does go into the spinal canal. So ultimately, they have a lot of similar effects. Both of them, most importantly, affect the sympathetic autonomic chain, which runs parallel to the spine throughout the entire thoracic region. And you can see on this picture on the right, it says sympathetic. Where the needle points to the sympathetic chain. When you numb up sympathetic chain, you suddenly decrease that sympathetic discharge, that activation of the sympathetic system that is related to surgical insult. Next one, please. And maybe click 2, 3 more times. Whether peripheral or neuraxial, perioperative blocks are essentially always performed utilizing local anesthetics. Definitely that is the case with neuraxial analgesia. Neuraxial analgesia involves injection of medication, like I said, to the spine itself, okay? And what happens is that in a case of epidural, you depend on the level of needle placement as well as amount of the medication that is being delivered to the spine. So that beaker on the left, it's supposed to give you kind of an example of what happens within the spine. The more volume you put in, the wider the anesthetic block. The medicine's not any stronger, but the block becomes wider. So this is how we anesthesiologists control the spread of the epidural block. As a result, when you put the numbing medicine with a little bit of opioid into the spine, as a result, you produce a dense dermatomal, segmental, sensory, motor, and also autonomic, the sympathetic autonomic blockade. And that, like I said, the level of the epidural can be therefore easily control and modify. Next slide, please. It is well-established fact that surgical stress induces profound neuroendocrine, metabolic, and cytokine changes. Epidural analgesia has been found to improve all of that. It does improve perioperative pain control, which is way superior from IV analgesia. It promotes better functional recovery. It decreases that stress response and catecholamine release. Epidurals have also been found to decrease the overall catabolic state as related to surgery and improve glucose control, which, as you all know, also directly contributes to improve immune system function. So ultimately, regional anesthesia is overall superior to general anesthesia in terms of perioperative pain control, perioperative morbidity, as it decreases pulmonary, cardiac, and many other perioperative complications. But even, next slide please, but it even decreases perioperative mortality. And if you look at the list of various surgery that I'm showing you here, it essentially every type of surgery benefits from epidural analgesia. But the question that we still must answer, that I have not touched on yet, is whether or not use of regional anesthesia improves cancer outcomes. Next slide, please. One should certainly think so, since we know that use of regional anesthesia diminishes the perioperative stress, and we already talked about how stress affects cancer development and progression. In many cases, use of epidural permits avoidance of those volatile agents that contributes to cancer pain, and that contributes to cancer, and it certainly decreases the amount of opioids that patients require, which also inherently have negative effect on immune system. Next slide, please.
All right, and we have another poll. Each of the following are considered to be benefits of perioperative use of epidurals, except, so you're looking for the one outlier here, decrease, would you pronounce that for me, Dr. James?
Oh, and it's my spelling, my bad, I ate the D. So it should be decreased catecholamine release, decreased mortality, decreased use of anesthetics that contribute to poor cancer outcomes, and complete inhibition of surgical stress response. So which of those is not what happens as a result of placement of epidural perioperatively?
Great, and thanks to our audience for jumping in so quickly with those responses. We'll go on to the next slide. It seems like we've got a lot of folks coalescing around D, with some also thinking that it might be B, decreased mortality.
So if we were to go back to slides, if you guys remember, I actually did show you a slide saying that essentially in every type of surgery, next one backwards. Yeah, so this slide actually shows that essentially with every type of surgery, placement of epidural does decrease both morbidity and mortality perioperatively. So the mortality is not the answer, but you're absolutely right. Even epidural is not able to completely eliminate surgical stress response, but it does eliminate a big chunk of it. So D is the correct answer. And let's go, yes, thank you. So let's start with talking a little bit specifically about paravertebral blocks. Do paravertebral blocks influence cancer outcomes? Next slide, please. So paravertebral blocks are most commonly performed to attain analgesia of chest wall, for chest wall surgeries, and most frequently breast cancer surgery. They can be done unilaterally, as I showed you before. So, if you give somebody an epidural, both sides of the chest are numbed up uniformly, versus if you place a paravertebral block, You can place a left-sided block or right-sided block. So in certain circumstances, they are actually superior in terms of technique to an epidural. This particular study compares outcomes of breast cancer surgery in patients receiving general anesthetic alone versus general anesthetic with paravertebral blocks for postoperative pain. All patients that received paravertebral blocks received a single shot injection with local anesthetics, but then they were divided into two groups. One received infusion of saline and one received continuous infusion through the catheter of local anesthetic. If you can click twice, please. And the patients that received general anesthesia, one more time, and those that received paravertebral block with local anesthetic, but then only saline for infusion, they did not do as well as patients that received paravertebral block with continuous infusion of local anesthetic thereafter. One more time, please. Click one more time. So those are the patients in yellow line. So as you can see, continuous infusion of local anesthetic via paravertebral blocks had significantly decreased survival probability as compared, had significantly lower or higher rate of survival as opposed to those who did not. Okay? So let's go and take a little bit more in-depth look into the biomolecular principles behind those occurrences. Like, why does it happen? What is it specifically about paravertebral blocks that promotes survival in breast cancer patients? So we do know that regional blocks contribute to the decreased sympathetic activation, decreased stress response. But can this affect cancer on a cellular level? So let's take a look at this study by Jowra and his group. What they did, they exposed cancer cells to serum of patients undergoing surgery under different anesthetic techniques. They divided their patients to those that received paravertebral blocks with propofol, and as you can remember, those are the good agents, versus those that received volatile anesthetic and opioids. And as you remember, volatile anesthetic and opioids have worse outcomes. They assessed the cancer cells based on the difference in their luminescence. So the degree of luminescence signified in vitro cancer cell apoptosis. So ultimately, the more luminescence, the more cancer cells are dying. Can you click one more time, please? And one more time. And what they have noted, so the serum of patients undergoing regional anesthesia, paravertebral blocks, showed more luminescence, suggesting more tumor cell apoptosis as comparing to the other patients. So therefore, likely suggesting decreased potential for metastases and breast cancer progression. Next slide, please. This is another study that I wanted to show you. This particular study assesses ability of human immune cells, the CD4s and CD56, to invade cancerous tissue, to infiltrate cancerous tissue in order to kill the cancer. So the patients in this study were randomized into two groups. One group received, again, propofol and paravertebral blocks, and the other group received general anesthetic and opioids. So breast cancer specimens were obtained from both groups and stained with immunohistochemically, I made it, to detect immune cell infiltration with the T helper cells and the natural killer cells. And again, the degree of infiltration within a tissue was measured by the intensity of the staining. So click one more time, please. So the tumor tissues exposed to general anesthesia and opioids had a lower degree of infiltration with immune cells as opposed to the tumor excised from patients that underwent regional anesthesia. Click one more time, please. These findings further support the hypothesis that a choice of anesthetic technique may in fact change cancer outcomes in cancer patients. Next slide, please. Unfortunately, although there is a lot of well-designed bench research studies supporting this notion, there's not enough clinical research that is well-designed. This is a systematic literature review that studies precisely that effects of paravertebral block on cancer recurrence. However, out of 467 studies they evaluated, only 15 of those studies actually qualified for review, and because of various methodological problems and maybe power of those studies. So not so many studies to make the determination from. Although many of the studies pointed towards benefits of paravertebral blocks, because of the low quality of those studies, it was simply impossible to either confirm or refute the claim that paravertebral blocks do in fact increase disease-free survival or recurrence or decrease the recurrence rate in cancer patients. It was, however, noted that the use of paravertebral blocks was associated with lower levels of inflammation, so that in itself may contribute positively to cancer outcome, and better overall immune response in comparison to general anesthesia and opioid-based analgesia. Next slide, please. So clearly, more well-designed research studies is needed to assess benefits of paravertebral blocks. But how about epidurals? Epidurals are in fact used way more commonly than paravertebral blocks for a variety of cancer surgeries, essentially pretty much anywhere within the body, with exception of things from the neck up. So abdominal surgeries, thoracic surgeries, lower extremity surgeries. For all of those surgeries, epidurals certainly can be used. And they have been around for a long time with a very strong safety profile and have been well investigated. Next slide, please. So let us start maybe a little bit with colon cancer. Colon cancer is a very common surgical malignancy. Many patients undergoing colectomy do in fact receive epidural for the purpose of perioperative pain management. And this retrospective study evaluates 588 patients that underwent colon surgery, out of which 377 had epidurals, and 189 patients underwent surgery without epidural. They assessed for overall survival rates, and they noted that 5-year survival in patients with epidurals was in fact 9% higher for patients who received epidural than those who did not. Next slide, please. On molecular level, patients undergoing cancer surgery under propofol and thoracic epidurals, as compared to general anesthesia, show evidence of decreased expression of various growth factors that contribute to cancer growth. Next slide, please. So this is another interesting molecular study. We're not going to go in depth. However, it is noted that epidural analgesia for cervical carcinoma specifically had positive effect on the activity of natural killer cells. It increased expression of antituminergic substances and decreased levels of protuminergic substances, protuminergic cytokines. Next slide, please. Unfortunately, in another study comparing overall survival with general anesthesia versus general anesthesia and epidural, it was actually noted that patients that simply had general anesthesia with epidural apparently had better outcomes and longer survival. It is, however, possible that perhaps the use of volatile anesthetics in both groups of patients offset the potential benefits of epidural use. Next slide, please. Overall, there is no uniformity in outcomes when it comes to colorectal surgery. There is just as many studies suggesting that there is benefit as there is study that suggested that there is not. And ultimately, we need more well-designed randomized studies to be able to determine that. Next slide, please. Now, we talked a lot about anesthesia, but we didn't talk much about postoperative pain management. And I have mentioned that opioids are not the best for cancer, correct? So as mentioned previously, there exists significant evidence that use of opioids negatively affects immune status. In this particular study, authors compare postoperative use of epidural analgesia versus IV opioid PCA in terms of management of pain for colorectal surgery with metastases. And what they noted is that patients that received epidural analgesia as opposed to IV PCA had much better chance on survival, 35% at 5 years, than in patients, the recurrence rate was 35%. Let me go back. The disease-free state was at 35% in the epidural patients and at 21% in the PCA patients. So approximately 20% difference in benefit of those that had an epidural analgesia as opposed to opioid PCA. Next slide, please. Unfortunately, those findings could not be reproduced for patients undergoing gastric surgery. There's very few studies on gastric surgery, but all of them equivocally show that there is no difference between epidural and non-epidural management. Next slide, please. Briefly, would like to touch on ovarian cancer as well as prostate cancer, as we will be finishing up. This study evaluates use of epidural versus general anesthesia for the bulking surgery for ovarian carcinoma. It's a decent-sized study, 648 patients. In this study, as you can see from the slides, it was noted that epidural use was independently associated with decreased risk of disease progression and death. Now, next slide, please. How about prostate cancer? Although there was no difference noted in this particular study among the two groups, one with general anesthesia, one with epidural, as pertaining to recurrence-free survival time, the relative risk of mortality in the epidural group was decreased by 19%. Next slide. Pancreatic cancer, as we know, is one of the most challenging malignancies to treat with extremely low survival rate. There's very few studies on pancreatic cancer, but in this particular study, in terms of long-term outcomes, the group of patients that received epidural was also associated with increased survival. So as you guys see, there's certainly some benefits there. We just need more studies on it. I think we're coming up on the last poll question.
We are indeed. So here we go, last question, and then you have a chance to ask questions of Dr. James. All of the statements below are true except A, all medications used in maintenance of anesthesia increase risk of cancer recurrence. B, anesthetic technique plays an important role in cancer outcomes. C, some analgesic medications have been proven to improve cancer outcomes. Or D, regional anesthesia is preferred over general anesthesia in terms of cancer recurrence prevention. So A, B, C, or D. Take just a few more seconds. Dr. James, it does look like
yeah, all superb. They answering questions wonderfully. So yes, you guys are correct. Of course, not medications used in analgesia and anesthesia have the same effect on cancer. Okay, well, so just to kind of sum up our lecture, I do have to say that at this point, there is some bench evidence supporting the benefits of regional anesthesia in reducing cancer recurrence and cancer-related mortality. However, the clinical data remains limited, and a lot of it is largely theoretical. More well-designed, randomized prospective studies are certainly needed. However, regional anesthesia has multitudes of other benefits, some of which we touch on during today's visit, but not all. So meanwhile, we should definitely continue using neuraxial anesthesia as well as peripheral nerve block techniques in our practices, as they have been proven over and over again for their superior analgesia, decreasing perioperative morbidity and mortality, and potentially even for improved long-term cancer outcomes. Thank you all for listening so attentively, and very much appreciate this opportunity. Thank you.
All right, and thank you, Dr. James. And now we'll wait for just a minute while those questions come in. Please go ahead and share your questions for Dr. James via Poll Everywhere. While we are waiting, let me ask a question that I've been wondering about through this lecture, and this has been absolutely fascinating. So this all focuses on the implications for patients who we know have cancer, but presumably, and I don't know what the numbers are, but there are a certain percentage of patients who undergo surgery for a variety of different circumstances that may have cancer, but that people are not aware that cancer is there. What are the implications of what you've discussed here for those patients in terms of choices for anesthesia?
Well, I think implications are exactly the same, in the sense that there are certain anesthetic medications that can enhance and promote tumor progression and micrometastases, and there are some that can inhibit it or at least not exacerbate it. Perioperative pain management is of utmost importance, and neuraxial anesthesia and peripheral blocks are probably, in my experience at least, the best way to accomplish this goal, at the same time limiting side effects of opioids. And with the current climate of opioid epidemic, which we have touched on before during my prior talks, minimization of opioids is also very, very important, as is for cancer development and progression. So I am a firm believer in regional and neuraxial anesthesia, and I certainly would recommend it to my family members, whether they are undergoing cancer surgery or any other surgery that's suitable for those kind of blocks.
Thank you so much. And while we wait to see if we get additional questions, I'm going to move forward and just say a few reminders and thank yous, and then we'll come back and check to see if any additional questions have come in. We do want to thank the North Carolina General Assembly for their generous support of the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. We want to thank Mary King, Veneranda Obore, John Powell, and Anita Woodyard for all of their hard work on this and every one of our other lectures. So thank you to all of them.